We ended the last talk with a question. If a treatment reduces the absolute risk of mastitis by 6 percentage points, what does that actually mean to the producer deciding whether to change protocols? That question leads us directly to today's topic, the number needed to treat and the number needed to harm. NNT and NNH are, in many ways, the most clinically useful numbers in all of evidence-based medicine. They take the abstract language of risk differences and translate them into something concrete and actionable. How many animals do I need to treat to prevent one case of disease? How many animals do I need to treat before one is harmed by the treatment? These numbers bridge the gap between research evidence and clinical decision making, and they're the numbers that make sense to clients, producers, and policymakers in a way that p-values and odds ratios simply don't. Let's build them from the ground up. NNT is simply the reciprocal of the absolute risk reduction. Let's walk through it. The absolute risk reduction, ARR, is the risk in the control group minus the risk in the treated group. In our dry cow therapy example from the last talk, the control group, selective dry cow therapy, had an 18% mastitis risk. The treated group, blanket dry cow therapy, had a 12% mastitis risk. ARR equals 18% minus 12%, which is 6% or 0.06. NNT equals 1 divided by 0.06, which equals 16.7. We round to 17. The plain language interpretation. You need to treat approximately 17 cows with blanket dry cow therapy compared to selective dry cow therapy to prevent one additional case of clinical mastitis in the first 30 days in milk. Now think about how much more useful that is than blanket DCT reduces mastitis risk by a relative 33%. The producer can look at the cost of treating 17 extra cows with blanket therapy, antibiotic cost, labor, withdrawal time implications, and compare it directly to the cost of one mastitis case, treatment, milk loss, labor, potential culling. That's a real economic decision with real numbers. The NNT is what makes it possible. A few things to keep in mind about interpreting NNT. Lower is better. An NNT of 2 means every other animal you treat benefits, which is a very effective treatment. An NNT of 100 means you need to treat 100 animals to benefit 1, which might still be worthwhile depending on the severity of the disease prevented and the cost and safety of treatment, but it's a much weaker treatment effect. NNT of infinity means the ARR is 0. The treatment does nothing. H is the mirror image of NNT, but now we're measuring harm rather than benefit. NNH equals 1 divided by the absolute risk difference, the increase in adverse event risk caused by the treatment. In our NSAID example, dogs treated with the NSAID had an 8% rate of GI adverse events compared to 3% in untreated dogs. The absolute risk difference is 5%, and NNH equals 1 divided by 0.05, which equals 20. Interpretation: for every 20 dogs treated with this NSAID, 1 additional GI adverse event is expected compared to not treating. Higher NNH is better. It means you have to treat more animals before one is harmed. An NNH of 20 is something you can work with. GI side effects are real but manageable. An NNH of 2 would be alarming. The key clinical use of NNH is in the benefit-harm trade-off. Here's how you put NNT and NNH together. If the NNT for pain relief with the NSAID is 4, you need to treat 4 dogs to adequately control pain in 1 additional dog. And the NNH is 20, you need to treat 20 dogs before causing 1 additional GI adverse event. Then for every 20 dogs you treat, you're providing meaningful pain relief to about 5 dogs, 20 divided by 4, while causing 1 GI adverse event. Whether that trade-off is acceptable depends on the severity of the pain, the severity of the GI event, and patient-specific risk factors. But now you have the numbers to have that conversation explicitly rather than vaguely. Where NNT and NNH become genuinely powerful clinical tools when you use them together. The clinical question is never just, does this treatment work? It's, do the benefits outweigh the harms for this patient in this situation? In our NSAID example, NNT for adequate pain relief is 4. NNH for GI adverse event is 20. The NNH to NNT ratio is 20 to 4, which equals 5 to 1. For every one additional GI adverse event caused by this treatment, approximately 5 dogs receive meaningful additional pain relief. In most clinical contexts, particularly postoperative pain where untreated pain is both a welfare concern and a recovery impediment, a 5 to 1 benefit to harm ratio is clinically acceptable. But context matters enormously. That GI adverse event, what does it actually mean? If it's occasional soft stool that resolves spontaneously, it's a minor inconvenience. If it's hemorrhagic gastroenteritis requiring hospitalization, the calculus changes dramatically. NNT and NNH give you the numbers, but the interpretation requires clinical and contextual judgment. And patient-specific factors matter too. A dog with a prior history of GI bleeding has a higher baseline risk of GI adverse events, which means their personal NNH is lower than the population average. A young healthy dog with no GI history has a higher personal NNH. This is where population level evidence meets individual patient care, and where the skilled clinician adds value that no published NNT can replace. The NNT concept extends naturally to screening and testing programs, and this extension is particularly relevant for epidemiologists designing surveillance programs or evaluating the cost effectiveness of wellness testing recommendations. The number needed to screen asks, how many animals do you need to screen to prevent one adverse outcome? The calculation is conceptually the same as NNT, 1 divided by the absolute risk reduction. But now the treatment is a screening test itself, and the benefit is earlier detection leading to better outcomes. In our hypothyroidism example here, without annual screening, 5% of at-risk dogs develop clinical signs, weight gain, lethargy, skin changes, before a diagnosis is made. With annual thyroid screening, that number drops to 2% because early detection allows earlier treatment. ARR is 3%, so NNS is approximately 33. This means you need to screen about 33 at-risk dogs annually to prevent one dog from progressing to clinical signs before diagnosis. Whether that's worth it depends on the cost of the screening test, the cost and impact of clinical disease, and whether early treatment actually changes outcomes. All questions that NNS helps you frame explicitly. NNS is increasingly important in veterinary practice as wellness testing and preventive care recommendations expand. Before recommending population level screening, it's worth asking, what's the NNS? How many tests does a clinic need to run to generate one actionable result? If the NNS is 500 in a low prevalence population, the cost benefit of routine screening deserves scrutiny. Math in this talk is in service of one goal, helping you communicate risk and benefit to real people, clients, producers, regulatory bodies, and colleagues in a way they can actually use. The single most important communication insight from NNT and NNH research is this: people understand natural frequencies far better than percentages or ratios. 3 out of 100 puppies lands differently than a 3% risk reduction, and both land very differently than a 67% relative risk reduction. They're all mathematically equivalent, but they communicate very different levels of impact. When you translate clinical evidence into client communication, the formula is simple. Pick a reference population your client can visualize, 100 animals, or the size of their herd, express the benefit as how many of those animals benefit. If I treat all 100 cows this way, about 6 fewer will get mastitis compared to the other approach. Then express the harm. For about every 20 cows I treat, one might have a mild injection site reaction. Then let them weigh those numbers against the cost of the intervention. That conversation, benefit, harm, cost, in concrete numbers, is what evidence-based clinical practice looks like. NNT and NNH are the tools that make it possible. We'll return to risk communication in depth in Unit 8, including framing effects, visual aids, and how the way you present numbers changes the way how clients hear them. Summary. NNT is 1 divided by the absolute risk reduction, the number of animals you need to treat to prevent 1 additional case. NNH is 1 divided by the absolute risk increase, the number treated before 1 additional adverse event. Lower NNT is better. Higher NNH is better. Together, their ratio characterizes the benefit-harm profile. NNH extends the same concept to screening. You need the absolute risk difference to calculate NNT. Relative risk alone isn't enough. And when you communicate these numbers to clients, use natural frequencies anchored to a population size they can visualize. In the next talk, the longest and most mathematically detailed in Unit 3, we tackle p-values, statistical power, type 1 and type 2 errors, and the critical distinction between statistical and clinical significance. These are the concepts that determine whether you can trust a study's conclusion, and they're some of the most heavily tested on the ACVPM exam. Pause the video and try your hand at working through this scenario. Let's work through all 4 questions. Question 1, NNT. ARR equals the risk in the unvaccinated minus the risk in the vaccinated, equals 28% minus 12% equals 16%, equals 0.16. NNT equals 1 divided by 0.16, equals 6.25, rounded to 6. You need to vaccinate approximately 6 shelter cats to prevent 1 additional URI case over 30 days. That is a low NNT, meaning this is a meaningful, effective vaccine for URI prevention in this population. Question 2, NNH. ARI, risk of lethargy in vaccinated minus risk of lethargy in unvaccinated, equals 6% minus 1% equals 5% equals 0.05. NNH equals 1 divided by 0.05 equals 20. For every 20 cats vaccinated, 1 additional cat will experience prolonged lethargy that it would not have experienced without vaccination. Question 3, NNH to NNT ratio and interpretation. NNH to NNT equals 20 to 6, approximately 3.3 to 1. For every 1 additional cat experienced prolonged lethargy, approximately 3.3 cats are protected from URI. In a shelter setting where URI spreads rapidly, causes significant welfare burden, and leads to euthanasia of untreatable cats, a 3.3 to 1 benefit-harm ratio is likely acceptable, especially because prolonged lethargy, while uncomfortable, is temporary and self-limiting in most cases. The recommendation would be yes, this vaccine is appropriate for routine use in a high URA burden shelter with monitoring for adverse events and client staff awareness of the expected rate of post-vaccination lethargy. Shelters with lower URA prevalence would need to recalculate NNT for their specific baseline risk. It would be higher and the benefit-harm balance less favorable. Question 4. The shelter director is correct that the relative risk reduction is approximately 57%. Risk in vaccinated is 12%. Risk in unvaccinated is 28%. RR equals 12 divided by 28 equals 0.43. So the relative risk reduction equals 1 minus 0.43 equals 0.57 or 57%. That's accurate. But relative risk reduction alone overstates the practical impact because it doesn't communicate the baseline risk or the absolute benefit. A more complete and actionable response to the director is, you're right that it reduces URI risk by 57% relatively. In absolute terms, that means 16 fewer URI cases per 100 cats vaccinated. So for every 6 cats you vaccinate, you prevent 1 URI. On the other side, about 5 in every 100 vaccinated cats will have prolonged lethargy, so 1 in every 20. Overall, the benefit-harm ratio is favorable for a shelter with high URI burden, and I'd recommend vaccination. But let me show you the numbers so your team understands both the benefit and what to watch out for.